And welcome back to the show. The New York Safety Net Hospital Coalition was formed in response to the urgent need to structurally reform the outdated Medicaid reimbursement rates for safety net hospitals in New York. Now, the coalition seeks to bring an end to New York State's two-tiered healthcare system through transformative changes, modernizing and equalizing, I should say, Medicaid reimbursement rates, and then standardizing eligibility criteria and promoting hospital spending transparency. Joining us now is the president and CEO of the SBH Health System, David Perlstein. And David, good to have you.
Thank you, Darren. It's great to be here.
Well, thank you. It's a great conversation to have and glad to have you sharing with us. And for somebody who may not be so familiar with the safety net, why don't you go ahead and take it away?
I absolutely will. And before I start, just so you understand kind of where I'm coming from, I'm a pediatrician by training. I've worked in the Bronx for 24 years now. I practiced in the Bronx up until about 3 years ago, right before COVID. Actually, I stopped in 2019, and I've been the president and CEO of the hospital since 2016. So SBH is a safety net. And what a safety net hospital is, it's a mission-driven private or public anchor institution that's often located in historically marginalized communities of color, such as the community that SBH serves, or St. Barnabas Hospital serves here in the Bronx. Our communities suffer from higher levels of poverty, primarily dependent on the Medicaid system to cover the cost of their medical care, which, as you mentioned, unfortunately, it does not, due to the fact that Medicaid only reimburses a portion of the full amount that safety net spend on providing that care. And that has put the entire system at risk for collapsing. The fact that our safety net hospitals are struggling to stay afloat due to this, what I would call an inequitable reimbursement system that has been exacerbated by significant underfunding for many years. And that's, you got to remember, Medicaid rates have been flat since 2008. So yeah, go ahead.
No, I'm sorry. No. I'll let you continue and then I'll come back with my next question. I didn't want to cut you off. Go ahead.
So, and this is a really big deal. And if I talk about the collapse of the safety net system, because you got to remember, we have estimated, the Safety Net Coalition, that there are about 30 safety net hospitals in New York, serving about 5 million people, and accounting for nearly 2,500 inpatient beds and millions of emergency procedural and ambulatory visits. We're usually the largest employers in our communities, and we collectively employ over 40,000 New Yorkers and have significant economic impact on the neighborhoods. But we're struggling.
And so when we talk about the issues that these hospitals actually face and the struggle, give us a little bit more in depth so that way people can get a better perspective on this here.
Sure. So this chronic underfunding that we have is really due just to the structure of the way healthcare is paid for. You mentioned a two-tier system, and when we talk about a two-tier system, we talk about systems of healthcare that serve generally poor people, which is under the Medicaid system, and then the kind of systems that serve wealthier patients, I would say wealthier and wider patients, where commercial rates can cover whatever losses occur due to other patients being in the Medicaid system, which are not that many. We really do recognize that this underfunding results in basically margins that are just terrible and usually negative, and it as a result hinders our ability to make investments needed to operate, and it forces us to constantly reevaluate our ability to deliver the care that our community needs and deserves. And I'll say it again, I think it's not only disrespectful, but it's foundationally racist. And I say that because the folks that are in this other tier don't usually have issues. And that's because, commercial payers often will pay 7 or 8 times more what Medicaid covers. And by the way, their costs are not higher. I would argue that because we're in communities that have typically suffered from unmet social determinants of health, and we saw a lot of these issues arise during COVID, such as stable housing, access to high quality foods, better educational and employment opportunities, personal safety issues, which usually results and has resulted in higher rates of preventable diseases such as asthma and COPD and high blood pressure, obesity, diabetes, anxiety, depression, substance abuse, and even non-accidental trauma. And as you know, and I'm sure you are aware, the Bronx still is is ranked 62nd out of the 62 counties in New York State that are ranked in order of health, wellness, and longevity. And the idea is that the safety net should be better funded to collectively address the issues. And honestly, it makes no public health or economic sense that it's not.
I mean, what can we do by way of policy, Dr. Perlstein, about really bringing some equity here? Because certainly there's some ways that we can go about making things a little bit better.
Right. So I think there are quite a few things, and there are things that the safety net the safety net coalition is trying to accomplish. But I'll tell you, even while we face financial challenges, and they're huge, we're still innovative, we're creative, we're impactful, we're mission driven. We just don't know how long we can keep it up. I will about a program that we're running right now at SBH, and that program is a wellness center. It's the photograph that I have on my screen. This is a result of a public and private partnership that we worked with a developer. We donated the land. They built 314 units of affordable housing that now is full. We actually saved 95 of those units for formerly homeless individuals. And in exchange, we received a wellness space that's about a 50,000 square foot space that has women's and children's programs. And on the second, and urgent care. And on the second floor, it has like these amazing holistic services, such as a fitness center and a teaching kitchen, community space, rooftop farms, exercise classes. And we're already seeing the impact. We've partnered with Bragg on violence interrupters, and we've been teaching boxing to a bunch of adolescents. We just hired actually one of those individuals who was involved in learning the boxing and now is teaching it. We have obesity management programs, and we've already have anecdotal evidence that our patients' BMIs, which is a measure of obesity, is dropping, and their diabetes are more under control. So we know we can do these fantastic things, but we need to get paid or have some sort of payment that actually covers the cost of doing transformative work. So, the solution is really to make sure that Medicaid more than covers the cost of running these kinds of programs. And again, COVID pulled back the curtain on the disparity. It's our communities that were hit harder than others. And our communities were already overburdened as it was, and now they're struggling to get back. And it's a challenge. So the Safety Net Coalition, and this is important, we got together after COVID. The Safety Net Coalition got together after COVID because we started working together during COVID because we were really challenged to make sure that we had the PPE and the supplies and the ventilators and places to send patients when we were full. So we worked closely together during that time. And after kind of the urgency of COVID fell back, we got together, I think it was originally 11 different institutions, all with the same challenges, got together to come up with a plan to fix this once and for all. And we believe that we have a way out of it. I will tell you that that New York State is making significant progress. The governor's office and the Department of Health are focused on this, and they're thinking about ways to improve the bottom lines at our institutions and make sure we have some capital, both for operations and equipment. But it doesn't come close to the Medicaid gap. It just doesn't. So our solution, and this is one of the things you were talking about, is to actually fix the structural payment inequity. And that means really working to reverse the years of underinvestment in our organizations and our collective organizations, and working with our partners at the state level to gain acceptance and approval.
I want to cut in because just for a second, because as you talk about this proposal, I know there's a proposal on the table. It
Yep.
proposes several things. I would love for our viewers to become a little bit more acquainted with what you're actually proposing, so
Yeah.
that way they can get on board.
Absolutely. And I will tell you, healthcare financing is the most confusing thing on the face of the earth. And even if you talk to most physicians who are not in hospital management, they won't understand it. So first of all, the idea is that we need to educate more folks to understand what the challenges are. But we are really trying to see, we're working with the state, and we're working with the CMS, which is the Center for Medicare and Medicaid, to increase the Medicaid payments for certain populations. And right now there is a program called the Directed Payment Program, which is a program that New York State and the CMS work together on. And that gives a Medicaid add-on. So the Medicaid volume that you have for certain patients. Right now, there are 18 facilities that benefit. We believe that we need to expand that to all of the hospitals that are impacted as we are. And that would include both downstate and upstate. So the idea is to first expand the DPP program from 18 to 30 hospitals who care for a large number of Medicaid recipients, and we can stabilize the entire system just doing that. The second bullet point I would say is to tie the payments to average regional commercial rates. I already told you that we can't cross-subsidize with commercial rates the way the wealthier hospitals can. And we need to be able to make up that difference so we can pay our bills. And we also believe that if we can tie the payments to average commercial rates, then we can actually start to stabilize the operations, and we can make the necessary capital investments in the programs and services that the community actually needs. And I'm talking about preventive care, special populations, behavioral health, which traditionally are not, well paid. Our wellness center, we lose money on our wellness center. I will never stop delivering care in that space because I'm making more of a difference there than I make anywhere else. The third bullet point, go ahead.
I'm sorry, no, we talk about mental health and wellness. We know that's a huge issue, particularly in communities of color. Having those sort of resources there. When you talk about the borough of the Bronx, we know, the Not 62 campaign is out there. We know that there's a lot of challenges in terms of our health. But the one thing where I think everybody agrees is mental health doesn't get a fair play. And so for you, I heard you say it, you're going to continue that continuum of care, even though it may not get the maximum amount of support that you're looking for.
I am not in the business to make money, right? That's really the key thing here. For some reason, healthcare in the United States is on the same par as building televisions. And honestly, it shouldn't be. It should be funded the right way and for the right reasons to get the maximal social good out of the programs. And so we think that by taking advantage of available subsidies that are out there and available funds that are out there, we can really change the trajectory. We can fix the 62 thing. We can at least start to 6. And by the way, I mean, honestly, Daren, it's a long game, which is why it's so hard to make things happen. You're not going to fix this in a year. This is a problem that has been going on long before I got to the Bronx. And my sense is, if we can start making the investments, both in the Bronx and in Brooklyn and in areas of Queens and other areas of the state that are impacted the same way as I am, we can start helping our populations get out of these cycles. And that's what our job should be. We should be partnering with folks that have the expertise and the resources to assist us in this process. But healthcare organizations have to be at the forefront, recognizing our job is not just to admit patients and discharge them. Our job is to keep them out of the hospital, invest in the community in a way that will keep them healthier, control their anxiety, which usually leads to the depression and leads to the substance abuse and leads to non-accidental trauma and violence. I mean, we have so many opportunities to do that. And I will say that if we can get the federal government to put in more, and there is a way to do that, and we did meet with CMS and we've talked to New York State about this, there's a way to actually maximize the available use of federal funds, and shift away from other programs such as the disproportionate share and vital access provider programs that the state can't get the matching funds on. So we believe also that by establishing this program, we could also work on establishing, reporting requirements that ensure, because you have to, that ensure the program is actually delivering what it promises, focusing on health equity, access, quality, experience, and operational efficiencies. We believe we should be moving forward towards value-based care. We should be really focusing on prevention and outcomes and not just pouring money down the drain. So we believe we're certainly positioned to lead, and we're hoping that the state and the legislatures recognizes that, and we really appreciate being able to come on here and at least spread the word.
Well, Dr. Perlstein, before we go, please give people an opportunity on letting them know how they can support the efforts and the things that you've got going on here.
I think that the best thing to do, and this is the power of a democracy, is that you reach out to your elected official and you basically talk about the importance of reinvesting or doing further investment in the safety nets, because we are the hospitals that take care of you. And if we don't exist, you lose the mission and you lose the focus that we have, which is to really be there consistently when nobody else is. So I would encourage everyone to learn that lesson early, because it's empowering, and your legislators will listen. Legislators need to be elected, as does the governor. So the more people out there speaking this truth, the better.
Well, Dr. Perlstein, I want to thank you so much for coming and sharing with us. I think it's a very important conversation to have, some much needed information. And thank you for the work with the Safety Net Hospital Coalition and all that's going on. Certainly, we'll continue to keep our viewers up to date and let them know what's going on there. Thanks much.
Thanks so much, Daren.